Hi, everyone, and welcome to the special simulcast of the Neil Haley Show and the Ultimate Men's Movement with our host, Dr. Jack Rocco. Dr. Jack, we've been talking testosterone in the last couple podcasts. We've also been talking about, male enhancement. But one thing that's being missed in a conversation, especially with your expertise, that involves non-surgical for things like arthritis of the knee, things in that nature. That's our topic today.
Yes, and I think that's something that we don't really push as much, but it's a core element of our clinic. I think all these guys, the guys that I treat, they have the testosterone issues, they have the belly fat, they have the mental health issues, and for God's sakes, they certainly have the orthopedic issues. That's my ultimate wheelhouse, board certified orthopedic surgeon. So I've been doing this for 30 years. I was in the surgical realm, and it just after 30 years of being on call, 30 years of taking ER call, 30 years of just the grind and the way healthcare has changed, I've kind of drifted into more non-surgical care, which I actually prefer in a lot of ways. I think it's more cerebral. A lot of times, orthopedics can be pretty straightforward. You have a fracture, you have something that's broken, you fix it. You have something that's, end stage arthritis, you replace it. And then there's different ways to do it, but in general, it's a pretty straightforward. But the real challenge is preventing surgery. And I'm a big proponent of preventing surgery. There's always complications. You always have those, the cases that you never forget. The case that goes in, and I've done, for years, I've done second opinions on patients. And, one of the most horrendous ones I remember is when I was in Pennsylvania. A guy comes in, he had both of his knees replaced, and he was miserable post-op. Like 6 months, a year later, he was miserable. And I looked at his knees, with the replacements, he was miserable. So I looked at his x-rays from pre-op, and he had hardly any arthritis, very minimal arthritis. So this was an aggressive surgeon that really shouldn't have been doing surgery at that point. And the guy told me that, Doc, the day before surgery, I went for a jog. I ran 2 miles the day before surgery, and now I can barely walk. Now, to me, in my opinion, that's a mortal sin of of a
Yeah.
surgeon. And I took the X-rays. I asked my MA, my medical assistant, who has not an associate's degree. She's not a physician, not a nurse. And I put the X-rays up. I said, which knee do you think I should do first? This guy wants a knee replacement. Which knee do you think I should do first? She looked at the X-rays. She's like, does he really need either of them done? They don't look that bad. And I said, I agree, but here's his post-op films. He already had his knee replacement. And she knew exactly who it was who did the procedure. He was notorious for being aggressive. And I have a friend from Erie who had a knee replacement. He ended up with an amputation. If you get an infection, if something bad happens, there's definitely a lot of potential problems with surgeries of all types. And if you're balancing that risk benefit ratio and you have bad knees, you can't function. I always tell people, being Italian, I like to talk with my hands. I would say that the decision to do a knee surgery, a knee replacement, is based on the level of your pain and the level of your function. So as your pain goes up, your function goes down. At some point, that it becomes an unacceptable mismatch. And that's the point where I think most people should decide on a knee replacement. It's never something that you have to have. It's never, a needed procedure. It's an elective procedure. I've seen people with horrendous looking knees who don't have that much pain. My knees look pretty bad, but they don't bother me. And then you have patients who have good looking knees, but they're in miserable pain. And, figuring out why that is, and a lot of the reasons why that is can be identified. They are simple things. Your weight. If you have a BMI that's excessive, someone who's obese, someone who's heavy, you can have mild arthritis on your x-rays and severe pain. someone who smokers, people that are just generally unhealthy. Those are some things. And the obesity carries with it a number of different factors. Not only is it kind of is counterintuitive that people with obesity are often malnourished. And, they're obese because they're eating horrible foods, oftentimes processed foods, or they're not eating a broad diversity of foods. They're not eating vegetables. They're not, oftentimes we see people from all walks of life, all stages. So that's a big thing that, you could be malnourished. That's also causing it. Um, so, my role now is really to prevent surgery, try to get people through without surgery, and I think that's fruitful for me. And most people appreciate that. They don't want to be put on a conveyor belt and just set up for surgery, booked, and then you meet the surgeon once or twice, and then you never see him again. Like that's not an uncommon practice in some orthopedic practices. Um, but anyway, so that's my in general goal with knee arthritis is to prevent a knee replacement. Now you have good, how are your knees, Neil?
They're very good. They were horrible in high school and college. And then
Good.
in professional wrestling, they stopped. And I think it's from building the muscle of lots of squats and lots of uh, you know, um, uh, leg presses. I don't have knee problem at all. I
Yeah.
think the mistake was I didn't have somebody that was working with me when I was still growing tall and say, you got to build this, you got to build out, you got to build a build. When I was
Yeah.
playing
You
basketball, I was 220 pounds. When I was a professional wrestler, I was 315 pounds. So you're
Mhm.
looking at a totally different thing, but my legs were big. Now they're strong. Like I'll go to the gym now. I can still leg press like stacks of
Yeah, I
stuff.
think we
But that
talked about that before when John Lehman came on. We talked
yeah,
about that before. And I think a lot of your issue being 6'10", it was a growing pain of sorts. And I find the kids when they're growing, they really outgrow their ligaments. Their bone
right.
grows, but the ligaments are too tight. So
I wish
that
someone would have told me that. And then also it goes back to I don't know. I should have been playing the other sport, which is football. I didn't know that, but but it's good. I'm glad I didn't either.
yeah,
It's
could be.
because of the head injuries. But
Right. Yeah. Well,
yeah,
yeah, but that's another factor, someone's muscle mass. And and sometimes everyone, there's all sorts of different body habitus, body shapes. There's a breed of people, a body habitus where some people have this real truncal obesity, large abdomen, and then they're like walking on toothpicks. They got very little muscle, thin legs. And that's a disaster. Those people, they don't have any cushion, any muscle, but they're still carrying a lot of weight.
right,
So I break down, I'll break down some of the treatment, the non-surgical treatment for knee arthritis. And the first one, we've already said it, but weight loss. That you need to get your weight down. I would, so many of these other things, pretty much everything else that I'm going to say is hit or miss. It either
right.
works or it doesn't work. But I would put weight loss, especially if you have, a significant amount of weight, I would put weight loss in a category that it will help, period. End of story. There's a non-steroidal anti-inflammatories may work, cortisone injections may work, gel injections may work, but weight loss will work. So I talk to most of my patients first and foremost if they need it. Some people don't, they really don't have excess weight, so they just have bad knees. But weight loss is my number one thing. Okay. And to get to the weight loss, um, once again, in the traditional healthcare, you don't have all the tools at your service to use. I can't prescribe testosterone in a typical practice. That's beyond my scope, and you start stepping on toes with other
Right.
people. But if I see someone in my office with knee arthritis, um, testosterone's another thing for men. So, but the testosterone is one, it builds your muscle. Two, it loses the fat. Three, it gives you a little more spunk and mojo to exercise. So I think, a lot of these patients, the men that I see, Testosterone could be a thing that's valuable for their knees. Anyways, so weight loss, hormone optimization, we'll put it in that category.
Okay.
Number two, anti-inflammatories. Those are your Motrins, your Aleve, your ibuprofens, anything, meloxicam, tramadol. There's a number of, anti-inflammatory medications that are great for knee arthritis. The problem is they're not so good for your gut. So, I do look at the whole body. I try
Mm.
to, it depends. Anti-inflammatories can be dangerous. A lot of our patients are on blood thinners. Um, if you're on blood thinners, you can't take anti-inflammatories. It tears up your gut flora. You can develop ulcers, GI bleeds, even some of the over the counter. When I was in North Carolina, I was good friends with the one of the uh, colonoscopists. He was a gastroenterologist. He would do all
Hmm.
the colonoscopies, and we're talking about it, different sources. And down south, the number one cause of ulcers and GI bleeds are those goody powders. They sell them. I don't know if you've ever been down there. And down south, they sell these little packets. They call them goody. It's the brand is goody powder. Basically, it's an aspirin. It's a ground up
Ah.
aspirin. They sell them, at the front counter of a convenience store. You pick them up. You just take them. You either dry eat it, or splash it down with, your water. But a lot of these, these guys down there, they use those a lot, and it's a big source of GI bleeds. So all those anti-inflammatories, aspirin, GI bleed is an issue. Once again, the risk is, people take thousands and thousands of dollars worth of anti-inflammatories per day or per year, but another risk. Then from anti-inflammatories, the next category I would put in there would be cortisone shots.
Hmm.
Cortisone shots work great. I've had them myself with my knee, and I've spoken about this a few times in the past. Post-COVID vaccine, I had a rip-roaring rheumatologic flare-up. Every joint in my body hurt. My knuckles were swollen. I had a face drop. My SED rate, which SED rate is a condition a marker of your inflammation. It's just a generic marker for your inflammation. And high normal SED rate is 15. 0 to 15 is normal. If you get to 100, if your SED rate is 100 or above, you've got some serious problems. You've got metastatic cancer, you've got deep bone infection, you've got some long-standing chronic inflammatory condition, chronic condition that's tearing your body apart. So I never had any issues, never had rheumatoid arthritis. My SED rate after I took the vaccine 2 months and when I was in my worst flare-ups was 83. So I was knocking on the door of metastatic cancer,
Oh my goodness.
bone infection, and I didn't have anything. I said I've been a healthy person my whole life, no issues. Said 2 months after getting my vaccine, I can't lift my shoulders. I couldn't shave my head. I couldn't roll out of bed. Like if I was laying on my back,
Oh my God.
look like this slight motion.
Well, you're very lucky that you were healthy. And if you
Yeah.
weren't healthy, probably you wouldn't be here.
Right. And who knows what it did. I have a friend from that period that he was a cardiologist and he ended up with blood clots and pulmonary embolism. Same thing. He was younger than I was, healthy, as healthy, if not healthier than I was, regular normal guy. Anyways, but at some point, I'm not a big fan of steroids. I've always been a more naturalist when it comes to this. But there was one day where my knee was killing me. I was hobbling, but not just that. I had the brain fog. My head was cloudy. I just, was sick from this inflammatory condition. And I had to go do a hip fracture. And I finished my office in the morning and I got to run over to do this hip fracture. And I said, I'm hobbling. My knee is horrible. So I snuck into a room, I grabbed some cortisone, and I gave myself a shot. And it was amazing to me how quickly it worked. So cortisone is a very effective treatment It calms the inflammation. Cortisone and steroids are the top tier medication for inflammation. That's why NSAIDs are called NSAIDs, non-steroidal. So these are the steroidal anti-inflammatories are the highest tier of anti-inflammatories. So I gave myself a shot and I start walking across the parking lot, and literally my whatever fog I had in my brain started clearing. Like, it was that quick of a response. And we hear different things in medical school, and some are true, some aren't true. But the party line always was, well, cortisone, it stays in your knee, it doesn't really go systemic. Bullshit. It does go systemic. Um, it does go, it transfers into the bloodstream through the capillaries. And I said, but I was amazed at how, and I was really inflamed. I was full body inflamed, which is probably what made it most noticeable. But yeah, walking across I'm like, oh, wow. Like, the world started clearing up. My head started clearing up. The headaches were going away. And my knee felt a lot better. So cortisone is a great way to do it.
Yeah.
The problem with cortisone is that if you do it repeatedly over and over again, it can also have a deleterious effect. It can erode some of the cartilage. I mean, it's not supposed to be there. All these things are not supposed to be there. So it's a caustic foreign agent that you're putting there. And your body also, like I said, you also get that systemic reaction, which can shut down your adrenal glands. So the cortisone is a great option for treating non-surgical knee pain, but once again, also with side effects. The other thing that I did for myself, which was actually the last injection I received, was a PRP injection. And I do a lot of these as well. PRP injections in the knee are definitely one of these alternative treatments, one of these new, up and coming treatments, but it's also one of the ones that insurance companies won't pay for. And, this is not a conspiracy theory. The reason why they won't pay for it is because there are no lobbyists out there promoting it. It's as simple as that. Because you can't promote something that is your own body. You can't patent your blood and your plasma. And that's what, with PRP, that's what we do. We draw blood from the patient, we spin it down in a centrifuge, and what that does is it ends up with um, a clot. The red blood cells end up at the bottom of the tube. All right, and then we actually spin it twice to get a highly concentrated plasma, and called platelet-rich plasma. And the platelets and the healing elements, some of the white cells, are concentrated in that plasma. Plasma is the thing that does the healing. When you get a bruise, it bleeds. Well, the blood is just a side effect of the bruise, but with the bruise also comes all those inflammatory fluids, your plasma, your healing elements, cytokines, interleukins, all these crazy biochemical processes that go on. And that's what does the healing. So with the PRP injection, what you're doing is you're removing the red cells, which can have a toxic element to them, because once they oxidize, they can, they'll leave byproducts and whatnot there. So it eliminates the red cells and gives you a high dose of the platelets and the plasma, the healing elements. And even with surgery, anytime we do surgery, there's always bleeding. But it's that bleeding, it's that inflammation, it's that swelling, that plasma that does the healing. When we do surgery, we go in, we repair something, we put it back, we screw it in place, whatever we do. But then the body has to heal, whether that be a fracture, whether that be an ACL reconstruction, a knee replacement. We put things in place, but if the body didn't heal, if someone has poor healing, that's when you get infections, that's when you get wound dehiscence and all sorts of issues. So the plasma and the platelets, they are the main healing element, and a PRP injection is one way to concentrate those elements and get that healing. With knee arthritis, what it does, once again, these things, I've seen them work tremendously. I've seen them work not at all. So all these things everything is in the, may or may not help. But what the PRP does, in theory at least, um, the cartilage on the end of the bone, that is arthritis. Arthritis is the cartilage on the end of the bone is worn down thin. There's cracks, there's fibrillations, there's little potholes, defects, divots, whatever you want to call them, that are in at the end of the bone. And the PRP will go in and interdigitate amongst those cracks, those crevices, almost like, like fixing a pothole up in Pittsburgh or down in Pittsburgh, that you put a little asphalt in there, that you smooth it out. So the PRP probably does something like that, where, it's going in, that plasma is going into those little cracks and crevices. It's providing a healing element. It brings in collagen, all those things which help with healing. So that's a good thing. And I think that's like I said, that's probably the high tier of non-surgical care. Um, the PRP injections. Oh, the other thing is the hyalgin injections. Once again, similar to what we do with the male enhancement, or what can be done with the male enhancement, similar to what they do with the face. Those same products, different formulation, but very similar thing. Is another thing that we can inject into the knee. And what that does, it's similar to the PRP. The gel injections, we call them gel, but visco supplement injections is another word you can use. Most people know it as gel or chicken fat. A lot of my Pennsylvania people, because some of it's made out of the rooster comb, the comb from the rooster. That's where they get the hyalgin. But yeah, that's another good option for non-surgical, similar to PRP. Probably just about as expensive. PRP, there are costs for, we need the centrifuge and the tubes. It comes in a kit. Like you have to get a sterile kit. So there's expense on that. And same thing with the visco supplement, there's an expense. Cortisone is cheap, relatively cheap, cortisone and lidocaine. So they go up in tier. But I think PRP and visco supplement are probably close to being on par, but there's not many studies in it because no one wants to fund the studies. The companies that make the visco supplement aren't going to put it up against PRP, aren't going to put it up against
No.
cortisone because they'll lose. So they put it up against placebo, so you either get nothing or you get their product. And, oftentimes, their product should be able to beat a placebo, but those companies are not interested in putting them up against, things that they don't sell. And that's unfortunately a lot of what drives research nowadays is ultimately the financial payback. What do you think about that, Neil? Does that
No,
cover?
I mean,
That
this
covers
is
a
all
lot.
interesting stuff that I don't know anything about, except it's interesting to know that there are other options than surgery. And you
Yeah.
only focus on the knees, right? And the elbow.
No,
What about the back? Anything with the back
I
or
don't. That gets complicated. In my career, I mean, when I was in the service, I was doing discectomies on F-16
okay.
pilots.
Okay.
I put F-16 pilots back in the cockpit after they're pulling G's and
Okay.
rupture a disc. But, I focus now mostly on the extremities, both upper and lower. And so
Knees,
my career,
elbows,
bunions, but I
uh,
don't do surgery. So
ankles, any type of ankles.
yeah,
Yeah,
like
yeah.
I said, I can diagnose and treat conservatively. If something gets to my partners that I have in the office, if it gets to the point where someone needs surgery, I refer to my partners in the office. So it's a great way. It's good for them. They don't have to go through so many non-surgical things. They can focus on surgery and seeing their post-op patients. They've got a lot of work to do as well. But to be able to go through a lot of those patients and just treat them non-surgically. I enjoy. You get to meet people and talk about their families and just for me being new here, get used to the area. But also, it really is the Lord's work. Here's a famous quote that they talk about when you're going through residency, and it's a great quote. And they say, a good surgeon knows how to operate. A good surgeon should know how to operate. A better surgeon knows when to operate. That's, timing is also an important thing. But the best surgeons know when not to operate.
Mm,
And that's really because you have to respect surgery. And I've done that my
right.
whole life. And I said, like that example I gave early in the episode, where a guy who was jogging the night before surgery, he ended up with a fungal infection.
Yeah.
He had his knees replaced again, had to revise his knees. It was a horrible outcome. And that's in my book, that's a mortal sin to operate on someone prematurely who didn't need it and they have a bad complication. Really unacceptable. So I'm trying to prevent that, trying to prevent early
Right.
surgery, unnecessary surgery. And I think it's a good role. Most people respond to it, at least to some extent, or it gives them time. They want to get to the spring, they want to get to the winter, whatever works with their work and their life. So
All right. All right. Go to theultimatemensclinic.com in New Bedford, Massachusetts, and you can schedule a call with Dr. Jack and his team today. And there's many different things you can treat at the Ultimate Men's Clinic. I appreciate it, Dr. Jack.
thank you, Neil. We're all
That
about longevity and youth.
that's so important. That was a special simulcast of the Neil Haley Show and the Ultimate Men's Movement. Guys, take care. Hold on.